The following video will demonstrate the correct technique for insertion of oral and nasopharyngeal airway adjuncts. Once airway obstruction is identified, immediate action must be taken to relieve the obstruction and maintain a patent airway. These simple airway adjuncts are helpful and often essential to maintain a patent airway, especially where resuscitation is prolonged. This video is designed to be used by student nurses in conjunction with a practical teaching session and directed reading, and as such is not inclusive of all you need to know before competently performing these skills. Additional learning resources will be identified at the end of the video. Always refer and adhere to local policy in the area where you are working when using oral and nasopharyngeal airways.
So the oral pharyngeal airway or Goodell airway is a curved hard plastic tube that has a flanged bite guard at the oral end. Once inserted, the airway sits neatly in the mouth between the tongue and hard palate. There are a variety of sizes available to suit small and large adults, and it is necessary to choose the correct size of airway before inserting. To size an oropharyngeal airway, hold the airway against the patient's face as it would sit in the mouth. A correctly sized airway should be equal to the vertical length between the patient's incisors and the angle of the jaw. To insert the airway, open the patient's mouth and check there is nothing in the mouth that could be pushed down into the airway. Suction if necessary. Introduce the airway upside down into the mouth until past the hard palate. Rotate 180 degrees as it enters the oropharynx. This manoeuvre lessens the risk of pushing the tongue backwards and further occluding the airway. If placement is correct, the obstructed airway will be relieved and the flattened reinforced section of the oropharyngeal airway will sit between the patient's front teeth and gums. After insertion, check the patient's airway and breathing using a look, listen and feel approach. You may need to apply head tilt, chin lift or jaw thrust manoeuvres to maintain correct alignment of the head and neck.
Caution: oropharyngeal airways are only suitable for use on patients who are unconscious. Attempted insertion into semi-unconscious patients may promote gagging or vomiting. If a patient is intolerant of an oral airway, they do not need it.
The nasopharyngeal airway is made of soft plastic, beveled at one end and flanged at the other. It can be tolerated by semi-unconscious and conscious patients who would be unable to tolerate an oropharyngeal airway. There is no reliable measurement method for nasopharyngeal airways. Size 6 mm will suit most small adults, size 7 mm will suit an average size adult, and size 8 mm will suit a larger adult. Some older designs of nasopharyngeal airways require a safety pin to be inserted into the flange to prevent the airway from sliding into the nose. If required, insert the safety pin before placing the airway in the patient's nose. Many newer nasopharyngeal airways now have a wider flange, which means the safety pin is not required. Lubricate the airway thoroughly using water-soluble lubricant. Check the patient's nostrils for obstruction. If evident, remove with suction. With the patient lying in a supine position, insert the airway bevel end first, vertically along the floor of the nose with a slight twisting action until the flange sits at the entrance to the nostril. Try the right nostril first, and if any obstruction is met, try the left nostril. Once the airway is inserted, check the patient's airway and breathing using a look, listen and feel approach. You may need to apply head tilt, chin lift, or jaw thrust manoeuvres to maintain correct alignment of the head and neck. Cautions: may cause nosebleed, may cause gagging or vomiting if the airway is too long, and it's contraindicated in patients with suspected basal skull fracture.